It's the end of the day and it's the end of the conference. So happy to be speaking to you guys today about breast imaging navigation. My name is Tricia. I am an imaging operations manager for UT Southwestern in the Dallas-Fort Worth area of Texas. I've been in imaging for 25 years and happy to be talking to you guys about this today. So we're going to talk about breast navigation, what it is. We're going to talk about breast navigation in the imaging spectrum and in the cancer spectrum, and kind of talk about the difference for that. We're going to talk about the navigation matrix and all the steps in the matrix. And we're going to talk about the benefits of having a navigation program. So Harold Freeman is basically kind of the father of breast navigation. Terry smiles because she knows who he is. It is an old picture, but he, you know what? There's not any better pictures of him because he's actually a pretty older gentleman. But he kind of came up with the navigation, the theme, the process of navigation. He initiated that in 1990 in Harlem, New York, and he really focused on getting rid of barriers to care. Kind of a fun fact, his son is a radiation oncologist in the Dallas-Fort Worth Metroplex. So I ended up working with his son on tumor boards and stuff like that. So, and his son, Dr. Freeman, is also just a totally different personality than this Dr. Freeman, and very shy and looks like him though. So I got to work with his son directly for 6 years. So what is patient navigation? Patient navigation is a process by which an individual, a patient navigator, guides patients with suspicious findings through and around barriers in the complex cancer care system to help ensure a timely diagnosis and treatment. The scope of patient navigation has been expanded to be applied across the entire healthcare continuum, including prevention, detection, diagnosis, treatment, and survivorship to the end of life. This is a definition that Dr. Freeman came up with, and bottom line, patient navigation is a process that is used to help patients overcome barriers to care. Patient navigation helps ensure that patients receive culturally competent care that's confidential, respectful, compassionate, and mindful of patient safety. So, okay, navigation helps patients overcome barriers to care. Well, what are barriers? Barriers are anything that might prevent the patient from getting a timely diagnosis or anything that is going to stand in the patient's way from getting the care they need. Those could be financial barriers or economic barriers, communication and information barriers, healthcare system barriers, fear, distrust, emotional barriers, transportation barriers, or bias based on culture, race, or age. But the most common barriers to care are the complex healthcare system itself. So I work for UT Southwestern. It is a huge healthcare organization. Patients have a very difficult time navigating such a huge healthcare organization. What are the next steps? What do I do next? How do I get from point A to point B? So a navigator is often that person that just helps that patient figure out what are my next steps and how do I get from here to there, and especially after a new diagnosis. And they can certainly help with these other kinds of barriers, or helping with identifying those barriers, or helping them with resources in those any of those other barriers. But a lot of times it's just helping with navigating in a huge healthcare organization. So the breast navigation matrix. A few of you maybe have heard of the National Consortium of Breast Centers. I know my friend Terry has, but the National Consortium of Breast Centers is an organization that is called a consortium because it's a mixture of breast navigators, breast radiologists. The navigators can be nurses, they could be imaging navigators, breast oncologists. It's a consortium of all breast health professionals. And the matrix is a series of steps in the breast care continuum, basically from A to Z. It's from patient recruitment to end of life. And they basically just made a map of everything that happens for a patient from patient recruitment for screening mammography to diagnosis to end of life. And I'm going to show you that matrix and how the matrix is used to help navigate a patient. And really, it's just a step by step. This is what's happening. And you can't see it here because it's too tiny, but I'm going to blow it up in little steps. But the navigation matrix is in basically two steps. There's the imaging matrix, and then there's the cancer matrix. And the imaging matrix is everything that happens in the imaging portion, from patient recruitment to patient is diagnosed with a cancer, or right up to when the patient's diagnosed with a cancer. And then the cancer matrix is right when patient is diagnosed with a cancer to end of life. So I'm going to show you the imaging matrix right from the beginning here. Oh, I got a pointer. Recruitment of patients, patient scheduling, welcoming the patient and collection of data, pre-screening, screening. We all know these steps. This is just, the matrix is just a way of, we're actually writing down the steps here. Diagnostic imaging, of course that can include mammography, breast ultrasound, diagnostic intervention. This could include ultrasound guided biopsy, stereotactic biopsy. We've got biopsy here, MRI guided biopsy. Level 1, this is notification of the biopsy results. And now we start with the cancer matrix, pathology results consultation on the diagnostic workup testing, treatment, survivorship, recurrence, end of life. So that's the matrix that the NCBC came up with, and it's just everything that happens from patient recruitment to end of life. Obviously, not all patients are going to experience every step in the matrix. So, navigation. What are the benefits of having a navigator really in the imaging spectrum? Because that's what I'm talking about. A lot of real comprehensive breast programs will have a navigator, but they have a navigator once the patient's been diagnosed with a cancer. So most of us are familiar with nurse navigators that are intersecting a patient once the patient's been diagnosed with a cancer. Well, that's great. But what about all the stuff that happened before the patient was diagnosed with a cancer? What about the patient had an abnormal mammography exam, and then she needed a diagnostic workup, and then she needed a biopsy, and then she had pathology results correlation, and someone had to explain all of the pathology results to her, and then she was referred to a surgeon who helped her through all of those things. So that's the value of where an imaging navigator can really be instrumental. There's so much value there. So that's navigation in the imaging spectrum. So what are the benefits there? So that kind of navigation, that begins in the imaging spectrum is beneficial because patients have a plan for follow-up procedures. And if you set your program up really well, then those patients are going to have that plan before they even leave your imaging center. Patients feel well cared for, and that we've addressed their abnormalities expeditiously. You know, gentlemen in the room, if your wife has an abnormal mammogram or she needs a biopsy, when does she want that plan for her next steps? Does she want us to call her in a week or two? Or does she want her next steps? Does she want to know when her next steps are right now? If your wife needs a biopsy, does she want someone to give her a call in a few weeks? Or does she want to know when she's having that biopsy today? She probably wants to know when she's having that biopsy today. She wants to leave your center, her center that she's having her diagnostic workup off. She wants to leave the center with a plan. And ladies, I'm sure you feel the same way. You want to leave with a plan. You want to know, I'm coming back when? I'm coming back on Tuesday for an ultrasound guided biopsy. I've already been given my instructions. I know what the plan is. I'm leaving with a plan, right? And then you want to know that Tricia's going to call me on Tuesday, on the following Thursday with my biopsy results. And I know that if they come back and they're malignant, she's going to set me up with a surgeon by Friday, right? You want to know what's going to happen. So that's the benefits of early navigation. Your turnaround times are improved. And if you're monitoring benchmarks, if you're participating in a program like NQMBC, National Quality Measures for Breast Centers, your benchmarks are going to be greatly improved if you have navigation in the imaging spectrum. So expedited care can improve patient outcomes. Maybe it's just perceived, but think about this. If you have a breast cancer that has a very high Ki-67 or a very high nuclear grade, I'm pulling on the emotional side here. If you're a lady in this room, or if you're a gentleman in this room that has a wife or a sister or mother, if that person has a high nuclear grade cancer, do we want to just, chill there for a few days or a few weeks maybe, or do you want someone to get on this quickly? I mean, there's no question. We want things to happen expeditiously. So whether it's perceived or it's just actual, anything that's going to improve timeliness of care, anything that's going to help that patient get care going more quickly, that's going to improve the patient outcome. Improve patient and physician satisfaction. Your physicians are going to definitely have a better experience if their patients are having more expedited care. I mean, if you're getting things, if your patients are getting seen quicker, the turnaround time is quicker, your physicians are happier. Rapport is developed between patient navigator early on. And I'm going to show you guys some examples, and I think you'll connect with those examples really well. Organizational trust is built, which can prevent system outmigration. System outmigration is obviously a big problem. You don't want your patients feeling like, you don't care if they come back or not. Guess what? If you don't care, they will leave and they will go have their surgery done somewhere else too. So keeping your patients from outmigrating is going to it's going to increase downstream revenue too. So those are all the things. Talking about NAPBC just for a second. NAPBC, what do they say about patient navigation? Well, the bottom line is NAPBC, if you have a program that is accredited by the National Accreditation Program for Breast Centers, and NAPBC is a program that is under the Commission on Cancer. It's one of the American College of Surgeons programs under the Commission on Cancer. So what they say is you have to have a navigation process in place with the goal of expediting care and facilitating communication between providers. Navigators should have formal training. That's what the 2018 NAPBC regulations say. You have to have a process in place, and your navigators have to have formal training. That's the 2018 NAPBC regulations. So, yes, I'm a certified navigator and have been since 2012. But love NAPBC, love all of our regulations. There are some new NAPBC regulations. They came out, they were effective January 1st of 2024. As you can see right here, they came out in December of 2023, but they were effective January 2024. And they got very granular with their requirements. They said a couple things. They said you have to have a navigation process in place, which was the same as before, but they also got very granular about the education. And they said that you have to have your navigation training done in a certain place, NCBC, and that your navigation certification has to be a certain thing, breast health clinical navigator. And so I was telling Terry about this a couple nights ago. NCBC changed their certification, and they didn't grandfather in navigators. So basically, I had to take my navigation certification again. Yay me. So anyway, fun. I'm not mad. I just had to pay $300 to take it again. Okay, but that's all right. I didn't study for it. I just figured, you know what? I either know this stuff or I don't know this stuff. So I'm just gonna take it and we'll see how I do. And I did okay. So $300 because the new one is accredited by an organization called ICE, not in any relation with this conference, but it's an accrediting body. So now the navigation certification is accredited, whereas it wasn't accredited before. And now NAPBC requires that navigators have the accredited certification. So just some fun stuff if you work for a program that has NAPBC accreditation. All right, so I'm going to show you guys are imagers, right? So you guys like to see images, and it's really bright in here, so I hope you can see them because I'm going to show you some cases. So I'm going to show you a case study, navigation in action. Let's look at some images. I don't know, we can try. Ooh. All right, is that a little better? All right. So we've got a patient here. She is 76 years old. She's got a personal history of breast cancer in her 40s with a reported lumpectomy as her treatment. She reports a family history of breast cancer, mother, postmenopausal. She's asymptomatic and presents for a screening mammogram. Well, did I go? I went, sorry about that. I was trying to hit this little thing. You can see this little lesion right here. Looks much better on this is the 2D static, and that's the 3D. She's got that spiculated lesion right there. And on the MLO view, same thing here. Here's her 2D, but on the 3D, you can really see that spiculation there. On the ultrasound, so she was recalled from her screening. We took her straight to ultrasound. There was no need to do any spot compression films because on the tomosynthesis images, we could see everything we needed to see. But on the ultrasound, when we brought her back, so we went from We did, if you look at the matrix, we went from scheduling and intake and recruitment. We brought her in, we did a pre-screening, we did a screening, we got our images, we recalled her, and then we bring her in for diagnostic imaging. So that's where we're at on the matrix. And then you look at her images on the ultrasound. This is lobulated. In the other plane, it's taller than wide. And if you look at this, that's, I mean, it's pretty ratty looking, but we did elastography. Is everybody using elastography on your ultrasounds? Everybody's looking at me like, oh. It's got some, you've got some other colors here. It's not all soft. It's showing some stiffness there. That's pretty suspicious. So, so our navigator here is taking health history, coordinates care with other physicians if needed, educates patient about the recommended procedure, which is going to be an ultrasound guided core biopsy, does informed consent, participates in the biopsy. So we do a biopsy and we do an ultrasound guided biopsy. And then you can see on the post-biopsy film, there's the clip right there. Okay. Pathology results, pivotal time in the patient navigation process. It's at that time when barriers to care can be identified. Educational materials can be provided for the patient for that specific disease processes. Referrals are made to appropriate specialists, etc. I like to send patients, my chart is so prevalent right now, or various electronic methods of getting patients results. I send patients NCCN NCCN guidelines for patients in their my chart all the time. I'll send them a my chart message with NCCN guidelines for, they make it for metastatic, for DCIS, for invasive. They make one for inflammatory, and they make them all in Spanish as well. So you can send patients NCCN guidelines in their my chart. Okay, so this patient, we did an MRI for surgical planning. She had an area of enhancement, and then we're going to go back to steps 8 and 9 on the matrix because she had an area of enhancement. So we went back to an ultrasound, targeted ultrasound for second look after the MRI, and then we did an ultrasound guided biopsy after the MRI. So level 2 is where the surgical team often steps in. It's coordinated by the breast navigator. It's our opportunity as navigators to educate patients and ready them for their surgical consultation. And then 11 through 13 is where the surgical team steps in. So this is that same patient, and that is her wire localization and her specimen image. So I just wanted to show what navigation did for that particular patient. So navigation helped this patient overcome the barriers in the complex healthcare system. This particular patient, we called this patient with abnormal screening results. Since it was a BI-RAD5, we did her consultation for biopsy immediately and performed the biopsy the same day. We had pathology back in 1 day and set the patient up for a surgical consult within 3 days. We called this patient back for her MRI and rescheduled her for a second look ultrasound on her enhancement and set her up for a second biopsy. So bottom line down here at the bottom, her time from screening to initial cancer surgery was 19 business days. And that includes having an MRI and an MRI guided biopsy. That is crazy, crazy good. That kind of timeline is amazing that we were able to get her from a screening to initial cancer surgery in 19 business days, and that's with an MRI in between. That is amazing. One more case study. This one's a lot quicker. This is an outside consult. So this patient called me on April 19th. This one was real recent. This was like last year. She had imaging performed at an outside facility, and she didn't know what to do because she had imaging done at a facility that doesn't do biopsies, like a multimodality imaging center. So she had a BI-RAD5, and she was like, I don't know what to do. They told me I needed a biopsy. What do I do? So she called me and she said, I've got a disc. What do I do? So she had a 4.9 centimeter mass that was a BI-RAD5, didn't know how to move forward. I had her bring in all her stuff, all her, you know, and I uploaded everything. That's her mass. There was really no question about what it was, obviously. I had her bring everything in. I uploaded everything. I got her scheduled for 2 days. She brought it in on a Friday, so I had her scheduled for the following Monday. Biopsy was performed on Friday, resulted on Tuesday, and revealed invasive ductal carcinoma, estrogen receptor 70%, progesterone receptor negative, and HER2 positive, Ki67 40%. I called her with results, entered her surgical referral, entered a medical oncology referral because she was HER2 positive. And she's actually she's in a clinical trial at UT, so she's doing pretty good. She's doing really good. She had her initial surgical visit on May 2nd, and last I checked, she was undergoing neoadjuvant, but she's part of a clinical trial. So, oh, and she sent me a card. Too sweet. So the Cures Act. What has it done to navigation? I think this is really important because these patients are getting their results, their biopsy results, at the same time as their referring physician. I mean, the moment a pathologist signs their pathology report, it's going into their electronic medical record, and patients are getting it via MyChart or whatever electronic medical record system. So what I find myself doing oftentimes is, especially if I know it's like a BI-RAD5, it's something I know is going to be cancer, I'm bird dogging. I'm sitting at my desk and I'm watching my in basket because I don't want this patient to find out that way. I already know it's going to be something, right? Nobody wants to find out that they have invasive ductal carcinoma or DCIS or anything else on their phone because they got a MyChart alert. So I find myself bird dogging the computer so that I can beat them. I want to call them. I want to beat them to the punch. I don't want them to get a ding alert on their phone and then them log in and find out they have cancer, because it's just so shocking. It's just a horrifying way to find out. I want them to find out from me, a human, someone they maybe already have a rapport with. Yes, ma'am. Oh. There's no way. There is no way to do that. We can't prevent them from. We can't delay their results from going in their MyChart. There's nothing we can do. So because of that, there is a document that we created that explains, and this goes into their MyChart when we do a biopsy, that explains the difference between the benigns and the high risk and the malignant, and it's very helpful. It talks about a papilloma, phyllodes, radial scar, all the different things. But it's still, you know, again, I mean, nobody wants to find out that they have a cancer from their my chart on their phone, right? So I'm still, I'm in a race. I'm in a game of me first, and that's really rough. So back to who should navigate. That's a great question. It depends on your practice and all the steps in the matrix, how they're being addressed in your center. If you're a comprehensive imaging center and you're navigating primarily in steps 1 through 10, I think an RT is a great fit. If you're a comprehensive cancer program and you're just kind of navigating in the cancer matrix, then, you know, maybe a nurse is great. I really think it's awesome when you have a full comprehensive program and you have an RT navigating in the imaging spectrum and a nurse navigating in the cancer spectrum. That's what makes a whole lot of sense. That's what we do at UT. We have imaging navigators and we have cancer navigators, and then we have a soft handoff between imaging and cancer. And for me, and I have another imaging navigator. I just only navigate for my Moncrief Cancer Institute, my particular location. But if I have a cancer at my location, then I'll enter a referral for navigation for one of the cancer navigators. So why do I think RTs are great imaging navigators? I mean, so I worked for Texas Health Resources a long time ago, and I helped them develop their imaging navigation program at Southwest. But they insisted on having a nurse for their navigator in the imaging center. It was kind of interesting because who trained them? Me. Am I a nurse? No, I'm not. But the nurse was the navigator. But that's okay. Nurses are great navigators, and imaging technologists are great navigators. Of course, you know, obviously I'm like RTs, yeah, we're the best. Why? Because I think RTs are really great communicators. We're super passionate, right? Right, Carrie? We're super passionate, and we're hardworking and driven and motivated, and we become part of the part of the patient's journey early on. We've already established rapport, and we're accessible to the patient in the early steps of the matrix. We're accessible to the patient in that imaging matrix. So I think that techs are really great navigators. So if you're thinking about an imaging navigation program, what is it? How would it look? If I hired an imaging navigator, what would that person do? Well, there's lots of things they could do. They could call patients with BI-RAD zeros and get them scheduled. They could schedule BI-RAD 3s. They could call patients with MRIs that have abnormal results and schedule them for their ultrasound second looks. They could educate patients about biopsies and do consents with them. They could schedule patients for their biopsies, obtain health histories prior to biopsies, explain procedures, obtain consent, coordinate care with physicians. Sometimes patients will be on blood thinners and various things. You'll need to contact cardiologists to make sure you have cardiac clearance for them to get off various blood thinners and things of that nature. Coordinate outside consults for referred for biopsies. Patients will be referred for a biopsy, and you need to get all their outside imaging and coordinate that. Securing grant funds, participating in the biopsies, holding pressure, addressing the biopsy site, conferring with radiologists to ensure biopsy results are concordant and what they want the follow-up to be, providing pathology results to patients or participating in results deliveries, assisting with patient surgical oncology referrals, entering the referrals, entering their medical oncology referrals, entering their surgical referrals. I do those things all the time. Assisting with providing educational materials, documenting your encounters in your medical record, supporting your organization's accreditation programs. You might be on the panel for NAPBC, entering pathology in your mammography reporting system, whether you have MagView, MRS, 10RAD, etc., entering their pathology. Documenting adverse events, if they had hematoma, bleeding, severe pain, anything of that nature from the biopsy, enter that into the medical record and your mammography reporting system. Participating in multidisciplinary conference and following up on patients that are sent to multidisciplinary conference. These are all things a navigator would do. So if you're thinking, okay, makes sense, we should definitely have a navigation program and we don't, what do I do? How do I get started? First, you want to decide on what kind of navigation program you'll have in your center. You want to have one that's for the imaging matrix, or one for the cancer matrix, or one for both. I would do a SWOT analysis. That's really helpful. And maybe even a project charter. Those are helpful too. Decide who you want to navigate in your center, whether it be a nurse, a technologist, or both. And get referring physician buy-in. It's easy for me in an academic organization like mine, because basically we have everybody buy-in. But when I was working for like Texas Health Resources, we had to work really, really hard to get referring physician buy-in. And it was a lot of work to do it. Consider performing a community needs assessment. Community needs assessment is a very big deal, especially if your organization is NAPBC accredited. In fact, if you're NAPBC accredited, a community needs assessment is a requirement. But a community needs assessment is basically a document that tells you this is what we need, this is where the deficiencies are, these are the needs in our community, and it'll help you figure out what are the barriers. Collaborate with local support programs. Find out what's available in your community. Find out where your local chapters of American Cancer Society are. Find out where your local cancer support programs are. And then promote your program. Work with internal marketing teams. Educate your own team, and be the voice of navigation. I feel like I'm like woo woo. Be your own cheerleader for your own program. I think an SBAR is something that can really help. I'm sure everybody's heard of an SBAR. It's a great communication tool. That's something that I've used for, hey, everybody, we need a navigation program. Let me show you. Let's start with an SBAR. So I've used an SBAR as a tool to communicate that we need to do something. There's just some navigation workflows that I have developed for getting communication and the flow of results and things like that. And if you download this presentation, if you're trying to figure out what you're going to do with workflows and things, that might be a helpful slide to you. This is a, oh, why did that, it looks weird there, navigation worksheet. I don't know why that looks weird like that, but this is a navigation worksheet where we just list all the patient's outcome, what we're going to do with that patient, and it's just more of anything like a checklist on how we're going to manage that patient. Just a tool. Navigation resources. These are some resources that are just really helpful for patients. One of the centers I worked at for THR, we got a grant, and we gave every new diagnosed patient this book right here. It was really helpful, Breast Cancer Treatment Handbook. And if they had a partner, we gave their partner this book as well. But there's lots of things you can do. I mean, if you can get a grant, write a grant to help buy some of your materials, And that was at THR. We got a grant and bought all these books, and we even bought mastectomy bras with grant money. It was great. There's lots of things you can do. These are those NCCN guidelines I was telling you about. If I'm giving a patient that very unfortunate news that she does have a breast cancer, I really encourage them not to go down a Google trail that could end them with getting, maybe misinformation. So I will drop NCCN guidelines for patients into their MyChart that's specific to the kind of cancer that they have: metastatic, invasive, ductal carcinoma, inflammatory. And again, they have them in Spanish. So that will help them with navigating through their individual situation. So I may have spoken a little fast. I may need to slow down a little bit. I don't know why I don't know why the format on this looks a little weird. The conclusion: importance of navigation. It improves sharing of resources, quality of service, increases patient and physician satisfaction, supports NAPBC accreditation, supports NQMBC quality programs, prevents systemic outmigration, increasing downstream revenue. Every patient that I don't diagnose, but every patient that I deliver these results to, I'm entering a surgical referral in our own system. So we're preventing outmigration, improving timeliness of care, enhancing continuity of care, which may result in improved outcomes. I don't know why it kind of looks weird like that. Yeah.